So hello and welcome to everyone to the second instalment of the Youth Type 2 Diabetes Case Study Series. Today we're going to be looking at adolescent age group. I'll start as always with an acknowledgement of country with the artwork we have here. So I'd just like to take a moment to acknowledge the Aboriginal and Torres Strait Islander people of the land that I'm calling in from today, which is the Gimuy Wallaburra Yidinji people. And just take a moment to acknowledge the traditional custodians of all the lands on which our panellists and attendees are dialing in from today. I take a moment also to acknowledge the important role that Aboriginal and Torres Strait Islander people play in the work that's done at Menzies, whether it be as researchers, advising our research, or as participants. That's absolutely vital. In terms of a bit of an overview of how things are going to work today, similar to last week, we're going to have 3 case studies. They're going to take about 15 to 20 minutes each. I'm going to read out the details of the case studies to our panellists, and then there'll be a discussion where I ask some questions. I'd also encourage the audience, if you've got some questions, go into the question and answer box and type away with your questions. It'd be great to see what types of things the audience would like to know, and I can ask them to the panellists about the cases that we've got. Forming our panel today, we've got Dr. Michelle Sherry. She's a GP and clinical lead of the Women's and Children's Program at Whirly Whirly. We've got Raymond Anderson, Aboriginal health practitioner at Borroloola. We've also got Jenna Matters. She's a diabetes educator and dietitian, calling in from Boab Health Services in WA. And we've got Dr. Emily Papademas, a paediatric endocrinologist from Queensland Children's Hospital. As a bit of a disclaimer, the information in these case studies is de-identified. It includes both factual and fictional information in order to highlight important aspects of care, but also to keep any potentially identifiable information confidential. We'll get into the first case study, A. So we've got a 15-year-old boy here who's recently been diagnosed with type 2 diabetes. A HbA1c over 14%. He's got acanthosis nigricans, negative pancreatic antibodies, elevated C-peptide. You can see the BMI and waist to height ratio there. Blood pressure, 132 over 85. The urine ACR is normal. You can see there the total cholesterol, triglycerides. He's got normal HDL, and you can see his LDL there. Looking at the liver function, ALT over what we'd expect, and also AST. A bit more information here. So talking about the background, this patient's got autism, also got anxiety, and a restricted diet and sensory sensitivities, which you can commonly see in autism. Over 5 litres per day of sugar-sweetened beverage intake. Looking at the social history here, living in a remote community, 400 kilometres from a major centre. No school attendance due to severe anxiety and outbursts. And when we're looking at the family history now, older brother was diagnosed with type 2 diabetes at 21 years old. He's managing that very well. Multiple aunts and uncles also have type 2 diabetes. So if we throw it over now to the panel, I might start with you, Michelle. From the information you've got here, what would your priorities of care be?
Yeah, so I think, I mean, obviously this is a very complex case, both medically, but, you know, with the neurodevelopmental background and just the context of the remoteness and the low resourcing. I think obviously there is, you know, the hypoglycemia is a priority, but I think in reality, what we need to do here is just take a really big step back and try and look at this child, this adolescent, from the point of view of, I guess, his context, so his family, his community connections, and look at it from the perspective of the autism. So I guess I'd be looking to think about how we're going to be able to, who are going to be the key people that we're going to be able to engage to basically work towards some behavioural change for him. We know that's going to be really difficult and there's going to be a lack of, you know, available people to help with that. So I think just sort of pausing and trying to figure out who are the key people that you're going to invest in, to then sort of build some supports around. I imagine the family's already at their at the end of their tether a little bit with him, with the outbursts and that sort of thing. So I guess what I wouldn't want to do is go in with a whole lot of advice and recommendations that are going to further stress the family. It's really about, I think the first priority is providing support to the family and trying to figure out how we're going to approach this with maximal support and scaffolding for the family.
I really like what you said about taking a step back. Obviously, there's a lot of information there and a lot of things going on. Just having a look at the bigger picture, I think, sounds really important. Emily, can I just ask, from a clinical perspective, you got anything else to add there? Any other things that stick out to you in that case?
No, I agree with Michelle. I mean, taking a step back in these situations is really useful to look at the child as an individual within their social context and looking at their, you know, their social emotional well-being, their role in community and within their family, and what's going on for this family day to day. I guess, you know, the priority is to reduce his glucose levels and work on reducing his intake of sugar sweetened beverages. But yeah, doing that in a way that is going to be, you know, meaningful might be taking a step back and doing that slowly within his complex environment. You know, his weight, his glucose levels, they're obviously something that we need to address, but taking that, yeah, slowly. I think as well, asking what his priorities are and what the family's priorities are. We've got our own agenda, but I like to try and ask young people and their families what their priorities or goals are. Like it gives a good perspective on what things might be easier to tweak or adapt first, rather than us rushing in and assuming what our priorities are the same as theirs. So yeah.
Yeah, thanks, Emily. I'll throw over to Raymond and Jenna now. You know, we're talking about a young person who lives 400 kilometres away from a major centre, you know, fairly rural, remote, and some of the challenges that come from that. I'll start with you, Raymond. What kind of resources do you think might be available that we might be able to draw on here?
Well, I sort of went off the internet and got some pictures and that. I don't know whether you guys can see that. I've sort of made this for myself to try and explain what diabetes is and the complications and risks and all that involved with having diabetes, and trying to work out a healthy lifestyle that suits them. So going back to, you know, this child that has autism and all these other problems, I'd probably like take a step back and maybe try to build a rapport with the family, the older brother, and maybe try and find something that this young fella would like whether it's fishing and going down and try and incorporate the education while you're down there doing something that he likes. I guess that's something I'd maybe try and start working on. Such a hard, yeah.
Yeah, it seems like building a relationship would be really important here. Do you find those kind of cultural activities and trying to structure your education around while doing something like that effective?
Sometimes it's always hard working out here and trying to engage with families and that. There's always, you know, they come forth sometimes, but most of the time it's so hard. Always chasing them, you know, telling them to come in and just follow up stuff. So yeah, it's a little difficult.
Yeah, definitely. And can I ask you, Jenna, also working in a relatively remote location, what kind of resources would you be thinking of that might be available that you could draw on here?
I suppose I'd be looking more broadly, as everyone's already mentioned, like we have our clinical priorities, but the priorities of the family and the boy might be quite different. So I suppose finding out what support they may already have and what might be working for them or not working for them, and trying to build on those supports that may already be there. So are there any youth services, NDIS support, or I suppose psychological supports or broader allied health supports that may be building blocks to help us get them to a place where they think they might be able to make those behavioural changes.
And can I ask you, Jenna, one of the first things you said there was around finding some way to be able to merge the clinical priorities that we have, which we all know around some of those measures, and then merging them with the family priorities about what's important to those individuals. Have you got any comments or strategies that you use to help, I guess, marry those two so they're working together?
It's a really good question. I suppose, yeah, those priorities are really important, especially the priorities of the primary caregivers and their, I suppose, attitudes and beliefs surrounding health. So I definitely always try and relate back to what they may be. So whether that's, getting out on country and doing those activities that everyone wants to be doing and everyone living a long, healthy life, reducing risk of complications, drawing on those family experiences and belief systems.
Excellent. Thanks, Jenna. And can I ask you in response to that question around trying to marry up those, I guess, personal priorities and also clinical priorities, do any other panelists have some comment on that?
I'd just probably add, Damien, that I think we just need to be really flexible, and you're most likely to succeed where your priorities are aligning with the family's priorities or the client's priorities. So if you can capitalize on those ones and be flexible, I think that's, you probably get more reward from that. So
yeah, definitely. And I might go back to you here, Jenna, just around the diabetes education here and how you might approach that. Raymond showed a resource that he uses to help describe some of that and some strategies that he used around, potentially going out of the clinic and forming that relationship. How would you approach diabetes education in this circumstance?
I suppose, firstly, it's, I guess, the greatest barrier to diabetes education is that engagement. So trying to find the community link or liaison person. So whether that's the Aboriginal liaison officer, Aboriginal health worker or practitioner, I guess having that engagement with the boy and with the family, they may be those people that create that link initially and help nurture that relationship. And then following on from identifying those primary caregivers and what their priorities are, I suppose, yeah, as we said, trying to marry those priorities and working out, can we focus on some of the family or boys' priorities first? Some of the things that they might feel could be easier to focus on, and building on the enablers and the strengths that the family already has. So certainly linking in, if possible, with the older brother and his lived experience of diabetes, and trying to draw out some of the positive learnings there, and perhaps also any of the aunts or uncles that also may be able to share their experience. Because it's likely that they will already know quite a lot and have a lot that they can offer.
Thanks, Jenna. That's some really good suggestions. Can I ask you, Raymond, if we're talking about nutrition with this young person, how would you approach that discussion?
Well, that's a bit of a hard one, because I always talk about, eating a bit healthier, making, if they like going to a shop, buying pies and a bottle of Coke and that happens every day, I try and sort of split it up and say, maybe if you do 3 days a week and eat it like that, but then maybe the Tuesday and the Thursday, instead of buying a Coke and a pie, maybe buy a bottle of water and a sandwich, you know. But living out here, you know, the pricings are a little bit up and down. Everything's expensive. Like the other day, I went into the shop and a little bowl of salad or a little container of salad was $15. And it's cheaper to buy 4 pies and a bottle of Coke. So doing the educational side of things, just understanding what they like to eat and maybe try and incorporate some healthy stuff like instead of buying a bottle of Coke, if you still like drinking soft drink, you know, maybe have a Diet Coke. Instead of having a pie, have a sandwich or a bowl of salad or something a bit healthier. Yeah, so just try and work on what they like and then go from there.
Yeah, definitely. It seems like making little changes is part of your approach.
Yeah, mate. Yeah.
Yeah, definitely. Jenna, I know you're a dietitian as well as diabetes educator. Any other comments there about approaching nutrition education?
I suppose as I'm primarily a diabetes educator now, I'm definitely trying to link in with the dietitian in my team and co-consult with the dietitian if that's possible or suitable for the family. Yeah, as I said before, building on that pre-existing knowledge of healthy eating of perhaps the older brother, if that's something that he's really taken on board with his diabetes management. And also reinforcing that the healthy diet or way of eating for diabetes isn't a special diet. It's general healthy eating that's good for the whole family, and trying to come from a whole family approach with that healthy eating, and I suppose focusing on those sweetened beverages first and foremost, if that's something that the family feels they have capacity to change.
Thanks, Jenna. I'll just check, Emily, I know you've got some bad internet there. I don't know how well you're able to hear or how well your audio is going to come through. Have you got any suggestions here in terms of medication? What might you start with here, and what kind of strategies would you use?
Yeah, hopefully you can hear me okay. I just wanted to add with the nutrition, I agree with all the other points. I like to also encourage the family to eat traditional food. Often it's very intuitive that families know that traditional foods are healthy options, and that is something that they're really, you know, I think we should encourage families to do if that's what they choose to. And often I find people are reassured when I say that's you know, that's a strength to use traditional foods for well, at any point, but particularly if we're managing someone with diabetes. So I just wanted to mention that, really supporting families to go on country and use traditional foods. With regards to medication, I guess, you know, it is a really important part of this young person's with his HbA1c of so it's greater than 14.
Yeah.
He's at very high risk of, as we all know, of acute and long-term problems with diabetes, and medication is one aspect of care, along with the nutrition, support for social emotional well-being and physical activity, that we would want to use. Metformin is first line. And generally I'd use extended release metformin and try and group that at the same time of day. So it's just one time of day that the young person's taking medication. He needs insulin at least, you know, until we can get some lowering of his glucose levels. He would need basal insulin with a HbA1c that high. You know, other oral hypoglycemic agents, wouldn't improve HbA1c to target, which is under 6.5. That's easier to say than to execute. You know, starting insulin is really complex, particularly if there's a strong family history of diabetes that getting an understanding of the young person's experience with insulin within the family setting can be useful to work out what some barriers and improving the enablers of starting basal insulin. In addition, being so remote, access to power and a refrigerator is really tricky to store insulin. So often trying to explore how other supports within the community can help, whether that be at school, although this young person is not regularly engaged with school or clinic, but it's tricky. It's we know what he needs, but trying to make that happen is where the time spent trying to lift up some supports for him. In him, I would be thinking about some other agents, so GLP-1 receptor agonists as a weekly injections, often, I guess, a more convenient way and effective way, but giving as a weekly injection reduces the burden on this young person in the complexity of their life. At the moment, there's some shortages, so that's tricky. But really, I guess the base, he needs metformin, he needs insulin. It may not be forever insulin, but with a HbA1c above 14, we're going to need insulin to keep him safe. And I would think about other agents early if there's no improvement in HbA1c, but often there's, trying to scaffold with supports can help rather than adding, lots of different types of medication. Just doing the basics well is, hard, but yeah, a goal, I guess.
Have you got anything to add to that, Michelle?
Only that I think, as Emily said, the theory is sort of the easy bit, and I think in practice a lot of this would be really, really difficult to implement. We don't really know how he goes swallowing metformin, just with his sensory sensitivities. Similarly, I'm not sure how he would go injecting, and whether there's really a whole process that might need to happen first in terms of working towards that through a sort of behavioural management process, maybe with, I'm assuming, Jenna mentioned before about NDIS, I'm assuming he would have some NDIS package, but what supports are actually available either on the ground or sort of remotely to support the family. I think even starting medication really could take some time, depending on how sensitive he is to all of those things. And yeah, I just feel that he's going to need a lot of support, at step one of probably even just trialing metformin. I also agree. Emily just mentioned school, and we said that he's not engaged at school at the moment. But I think that would be something that, as part of his overall strategy, we could start to think about. And for us, in our work, schools are often a really good support network for people having medication. So I guess it would just, I'm not sure what his capacity is to go to school and what the school's capacity is to meet his demands, to meet his needs. But I think that would be something that you'd want to be exploring sort of at the same time, because it does become one more support structure in that overall medication strategy.
Thanks, Michelle. That also touches on one of the other questions that we had in the chat box there, which was around what would you suggest in light of sensitive sensitivities and behavioural changes likely making an injection very difficult. And yeah, I think you touched on it there. It's extremely difficult. It's probably slowly by the sounds. Any other comments to that question? Okay, I might move on to the next question. Emily, how would you go about managing the comorbidities here?
Sorry, Damien, could you repeat that? It was just breaking up.
No problem. How would you go about managing the comorbidities in this patient?
Thanks, I mean, yeah, comorbidities are tricky. So along with his his autism and anxiety, they're, you know, intertwined with his medical or diabetes. So management of that is tricky without other support services involved, and that would depend on which setting you're at. But, you know, access to psychology is pretty limited in remote settings, or other child developmental pediatric services really are sparse. If that was a resource available in the setting, and I would try and include them in the overall plan for this young man. Although, yeah, in remote it's pretty limited at times. His other comorbidities, so his I can't remember his BMI, but he was obese with a central adiposity, so really working on weight management and nutrition, but in conjunction with what is achievable within his family setting. He does drink a huge amount of sugar, sweetened beverage, so that would be, you know, equivalent to almost 200 kilos of sugar a year. So that's, you know, seems to be, if it was achievable, a target to achieve first, to reduce that amount of sugar consumption and swapping out as able. He's got elevated triglycerides, which isn't surprising with his HbA1c greater than 14%. That's very common when we see young people with type 2 with that high glucose levels chronically. And I'd expect making some nutrition changes and medication. If we saw a reduction in his glucose levels, that would, you know, we often see that triglyceride levels come down along with that. He's hypertensive, but it's and ideally you would think about starting medication, but it's not the priority if we can address some of the other comorbidities first. I think they all go hand in hand. It's just working out what will be the best bang for buck, what's going to be, you know, something we can work on. Ideally it would be intake of sugar, but, you know, is that what the family can do? And trying that first and really focusing on one area that might have flow-on effects to his other comorbidities. I don't know about eyes. I don't know if he's had an eye review, but would be linking in with eye reviews if able. And his urine ACR was normal, I think, but I'd be monitoring that. Really, he's got lots of comorbidities related to his weight and his diabetes, and they're all interconnected. Working out which one to focus on first will have flow-on effects.
Thanks, Emily. Anything to add there, Michelle?
No, I agree. I think it's great to, you know, prioritize some of the nutritional issues and managing the diabetes, and hopefully you get to build on that down the track. But I think that's important, not to overload client.
Definitely. A couple of interesting comments in the Q&A, which the audience can see. We'll move on to the next case. So, sorry. Okay, we now have case 2, which is L. So we have a 14-year-old diagnosed with type 2 diabetes at 7 years old. Complex family dynamics, again, little school engagement. And there's a note here of self-discharge from hospital at the time of diagnosis, ongoing difficulties with engagement with healthcare, again, living in a regional town. At 7 years of age, a diagnosis HbA1c was 9.2%, negative pancreatic antibodies, normal C-peptide, The BMI is on the 85th percentile, weight 90th, height 85th. And now at 14 years of age, we've got a HbA1c of over 16%, 12 months post-diagnosis. So basically for 6 years, the HbA1c has been elevated to around those levels. Intermittent ketosis, up to 3.3 millimoles. BMI is 15 now, weight's 35 kilos. There's no acanthosis nigricans. Only 1 kilogram of weight gained in the last 7 years. 7 kilograms weight loss after being commenced on a GLP-1 receptor agonist. You've still got negative pancreatic antibodies, very low C-peptide. And you can see at the bottom here, the APPL1 gene, query whether there's significance with that finding. So quite medically focused here, so I'll pass over to Emily and Michelle. I'll start with you, Emily. Have we got the diagnosis right here?
I mean, he's got diabetes, but it's just working out what his phenotype of diabetes is. We know that type 2 is common in this population, this age group, but his phenotype appears more like an insulin deficiency for type 1 type phenotype, with weight loss, ketosis, and now a low C-peptide. He's not, his BMI is low. He's got no central adiposity and no evidence of insulin resistance to suggest type 2. He's got no acanthosis nigricans. So I'd be leaning to, he has an insulin deficient phenotype. The antibodies are negative. I would think about repeating them if they haven't been done in the last 12 months, just to see if there's been a change. But also think about MODY or other causes of pancreatic insufficiency. I guess the main thing here is that he's not the typical phenotype that we, there's no kind of typical phenotype, but his phenotype is more insulin deficiency because of his low weight and his ketosis. And so management would be quite different to someone who has a resistant picture with acanthosis and central adiposity. And thinking about, other rarer forms, MODY, would be things you'd do, but I guess it'll, the management he'd need insulin in some capacity.
Mm-hmm. Michelle, have you got any other thoughts here around some of those questions around diagnosis, alternatives?
No, I mean, I think my perspective from the primary healthcare point of view is just that there's a lot of red flags in there. And I guess it sort of highlights the importance of doing some of those baseline investigations, not just assuming in each case that it is type 2 diabetes. And I think sometimes that's something, because there's quite a few blood tests to do at diagnosis, and sometimes we try to avoid that, but there is a real reason that we're doing that. So I think that's really important to remember. And then to watch for those red flags sort of over the course of the coming years. So it just highlights and then I would obviously just defer to Emily. But I think it highlights for me the fact that, these things are not always as straightforward as we would like to think, and we have to be on the ball for that.
And in terms of medical management options, Emily, what would you avoid here and what would you suggest?
I mean, well, he's had GLP-1 and lost quite a bit of weight, so I would avoid GLP-1s in this setting with low weight, having someone who's not overweight or obese. That wouldn't be kind of high up in the priorities of medications, and can be quite harmful if such as in this case where it has caused or contributed to quite significant weight loss, and in someone who's got a low BMI to begin with no weight gain, 1 kilo in 7 years. That's pretty dramatic. And so I definitely avoid GLP-1s in this setting. He needs insulin, and we know that because we know that now looking at this case, but as it evolves, it can be tricky because we're seeing more type 2, but type 1's very common in the general population. So just keeping a foot on it. But his phenotype's insulin deficient because of his low weight, no acanthosis, low BMI. So that would need to be started early. I would metformin, whether or not we start that, I think it's reasonable to start some metformin, but really insulin's required with this high HbA1c. And I would also certainly avoid SGLT2 inhibitors for him because of his history of ketosis and the risk of euglycemic DKA or diabetic ketoacidosis with normal glucose levels. So I would steer clear of those while, firstly, we don't have a lot of evidence around them in young people, but also with his background of ketosis would be potentially quite dangerous for him to develop ketones and go into a ketoacidotic state. Again, it seems it's much easier to say these things, but to implement them is really the hard part.
Mm-hmm. And Raymond, I might throw over to you here. You mentioned in the last case study, engagement can be really challenging, and we've got here a case of a young person who doesn't seem particularly engaged with the healthcare system. Where would you start for someone like this to maybe try and bolster some engagement?
Look, wherever I can, if I see him at the shop, say good day and that, just slowly sort of chip at him. If he's with his mates and that, sort of ask to come to the clinic, come pick up some resources or anything, just come and have a coffee, just come and have a sit down. If I see him walking on the street, give him a lift, and just slowly sort of build that rapport and try and sort of work towards the family as well. Friends, brothers, slowly sort of try and maybe get them together, or just sort of slowly chip at him until he feels a bit more comfortable to be open and honest and willing to have a go at anything. I will make a point that seems like he would take the GLP-1, and he will be keen on trying insulin. So that'd be the best sort of treatment option, I guess, for him. He's willing to go down that road, is another question. Just building a relationship and engage with him as often as I can. I know it's busy in that, but wherever, whenever, just say good day, how he's going, maybe see what he's eating. Just slowly chip away.
Yeah, thanks, Raymond. That's a really good point. It's hard, isn't it, to build up, and it really takes time to make or foster some of those relationships with the clinic, but it's so important. Can I ask you, Jenna, have you got anything to add here as a diabetes educator? Any other thoughts that you might add to this case?
I think Raymond covered off the most important first things. Yeah.
Excellent.
Could I just add one more thing, Damien? I just think this is also a good example where we probably also need to step back from just the diabetes as well. He's got, there's a lot of other things in his social history that might indicate, that with the family dysfunction and all that sort of thing, but there might be some underlying trauma or even neurodevelopmental problems, and having a really holistic approach would probably, at this point, when you're trying to engage and make those connections and plan, I think it would be really useful. And the other thing was just a plug for, and I know it's not available everywhere, but I think he'd be a really good candidate for some peer support, because you may not be able to draw on the family's strengths as much to support him. So looking for peer support options would be a really good one.
And Michelle, could you give any insight into what you've done at Worley in terms of peer support, just briefly?
Yeah, I'm conscious that we're pretty lucky that we have a monthly peer support program for youth diabetes and we find that, and it's mainly around just engagement, being connected and socializing and building relationships and rapport. So it's not a clinical program, although there's some education involved. But I think what we find is that the young people that take up the offer of that most are the ones who are most disengaged and looking for some sort of connection or support the most. So I think when we hear the story that the family's not particularly engaged or not able to function and well enough to help support him, then that would be a good, a good marker that maybe the peer support program would be helpful.
It sounds like a real asset to your clinic, Michelle. Okay, I'll move on to the next case. Okay, so case 3, diagnosed at 13-year-old, HbA1c is 10.2% on a background of solitary right kidney dyslipidemia as a result of low HDL. BMI 22.4, waist to height ratio 0.54, urine ACR 67.8. We've got a strong family history here. We've got a mother who had type 2 diabetes, GDM in pregnancy, maternal grandfather, great-grandfather, and uncle with type 2. Younger sister diagnosed with type 2 diabetes at 8 years old, so a really strong family history here. What's the social complexities with this case? We're living in a regional town, little extended family support. Mother's the carer of the grandmother with dementia. We've also got a background of food insecurity, domestic violence, no fridge or washing machine, previously minimal school attendance and depression. So here, obviously, we've got a complex case. I'll start with Raymond. When you're seeing someone who's got these really complicated circumstances, where are you starting and what kind of conversations are you having with the team more broadly?
Well, understanding the background and the lifestyle, where they live, like not having a fridge, not having food security. So understanding their lives and what they eat, what sort of treatment options are they already on. Just sort of slowly sort of have a look at what the background is and then sort of go from there, I guess.
Definitely. Jenna, have you got some thoughts here in terms of priorities for the healthcare team and for the family and patient?
I think some of the clinical priorities quite obviously would be the hypoglycemia, diabetes, and preserving kidney health or function. But acknowledging that those priorities could be very different to that of the client and the family. And I suppose finding out what those are and if there's any common ground there, and what the lived experiences of everyone else in that family around diabetes have been, and trying to draw out if there's been some positive experiences or if there's been some barriers, ways of working around those to try and change the pathway for this young person.
Thanks, Jenna. Michelle, can I ask you as a GP, you've got a patient like this coming through your doors, who are you looking to get involved in the care?
So I guess similar to the last two cases, obviously, I mean, she's at an age where we want her to be central to her own care, but we would be looking to draw on family support and kind of be able to explore how we can support the family to support her. But we're going to need, I think, just in terms of the demands of the family or on the family already and the obviously low resourcing, I think we're going to need much broader support than that. So you'd really be looking again, like potentially a school, potentially peer support programs, and looking to maybe additional services that can support some of the social issues on the you know, the food security and the other sort of lack of basic facilities to prepare and food and to be able to live. And also potentially more support for the grandmother that they're caring for. So, you know, sort of looking for whatever services are available that are going to support the day-to-day functioning of this whole family.
Thanks, Michelle. Emily, what are your thoughts on initial medical management here?
Yeah, I mean, this is a really tough case because she's very vulnerable from her social and like environmental complexities. There's just many things that are going to impact on how we can move, you know, make a plan with her and her family, particularly with food insecurity and no access to a fridge, and also the exposure to domestic violence and depression, you know, trauma, with really limited support within her family, with her own mother caring for her grandmother. So it's really tricky. I think just going back a step, I would try and ask her what her priorities are about what she thinks is achievable and what she wants to work on first. Often young people will, when you ask, they might volunteer that they want to work on weight or the food choices or walking, or so I'd try and use those strengths, that information, to incorporate that as part of the plan. I mean, if we were just to look at her glucose levels as an isolation, which is not what we can do, the real life is she needs metformin and she needs insulin for a period of time until we can wean her off once her HbA1c is reduced. But it's really that context of how are we going to give insulin if she has no fridge and she doesn't have anyone to support her. She's minimally engaged in school. Can we try and someone at school who might be able to help and administer insulin even 5 days a week as a start? And I'd be thinking about some of the agents in her case, GLP-1 receptor agonists, or if she's completely against injections and that wasn't an area to work on, potentially if her renal function was okay, if her EGFR was reasonable, so we weren't thinking about renal impairment with that one kidney that we need to protect, thinking about SGLT2 inhibitors, if tablets are achievable, but we know that those agents are have some evidence in adults about cardiovascular and renal protection. We don't have that evidence in young people yet. I guess it's within this social complexity, having that conversation with her about what is achievable, but really drawing on whatever supports we can to be able to give her some medication and protect her kidney.
Thanks, Emily. Michelle, have you got any other thoughts there around, I guess, further medical management or comment there around managing renal health?
No, not really anything additional. No, I don't think so.
Sure, thank you.
Sorry, I might add, Damien, sorry, with her renal health, I didn't quite touch on that, but with these, I mean, all kidneys are vulnerable, but someone with one kidney, you get a bit nervous, and really keeping an eye on blood pressure is important. In saying that, adding antihypertensive is, if it's indicated, it's not useful if she's also not taking any of her medication for diabetes management. So just having that conversation about what's doable, what's for her in her setting, but trying to manage blood pressure, keeping an eye on her urine ACR, her urine albumin creatinine ratio, improving the monitoring early if there's evidence of renal impairment. Really, she's at quite high risk in the long term.
Thanks, Emily. And Raymond, I'm going to go to you again here around engagement strategies. Yeah, we've got a really complex social circumstances here, obviously, from what we've read through there. And there's some comments earlier around the maybe looking for additional supports of how we could, wrap some supports around this family to help there.
Yeah.
Have you got any suggestions or thoughts there about how we could approach some of those conversations?
Well, maybe finding someone that should look up to that maybe is dealing with diabetes, same thing as her. Have her sister involved because she looks like she's 8-year-old and diagnosed with diabetes as well. Maybe, I don't know, sort of working with her, being her, maybe put something in her head, like a mindset that if she can control her diabetes, then her sister might follow and look up to and sort of manage it just as well if she could. Someone, whether it's family, but the role model, I'd sort of maybe look at, because she's so young. Yeah, might be a little bit hard for me to engage with a 13-year-old girl without having other females there. So maybe find another female health worker, maybe to sit in and just build that rapport build that relationship and try and get to know them and move from there.
Thanks, Raymond. Okay, so unless there's any other comments on this case, I'll just pass over to the panel, I guess. Jenna, have you got any final thoughts here on this case?
Just adding on to what Raymond said there, I suppose trying also to look for that female health worker that may be a really good link. So whether that's a child health nurse or, female Aboriginal health worker, school health nurse. Yeah, and I think it's a great idea to have that role model for the girl, but also to use that motivation to be that role model for her younger sister as well is super important.
Definitely. Thanks, Jenna. Emily, have you got any, final thoughts on this case study or the case studies that we've talked about today?
I guess my only comment is that, just how amazing the local community clinic staff and other support services can be in management of these young people. Often they've got the answer or an answer to help support this young person. If as someone who may visit a community, a handful of times per year, it's encouraging to have such resourceful people in the clinic who really know what's going on, and often have, Raymond and Jenna, they have some of the knowledge that can help support these young people. So I really, I don't think anyone should downplay their role in the management of these young people. I think it's really important, all the work that the clinics and schools provide, etc. So.
Thanks, Emily. And Michelle, what about you? Any final thoughts from this case study or the others that were presented today?
I think one of the things that is really striking about this particular case study was just the sense of disempowerment and chaos in this young girl's life. And I think the most critical first step was to provide some small bit of hope and some small pieces of control that she could then build on. So I think, trying to, it's obviously a really scary diagnosis, and there's some need to make sure that she's aware of how delicate the situation is with only one kidney, etc. But at the same time, it's really important to make sure that people walk away with a sense that there is hope and there is support, and that they can little bit by little bit take some steps to control it. And I guess to have some control, I should say. And I guess, knowing that that's going to be a lifelong journey of building on that to try and step by step increase the amount of autonomy and control that she has in her life.
That's a really good point. Thanks, Michelle. And Raymond, I'll throw over to you to finish. Have you got any thoughts from what we've talked about today? Obviously some complex cases and things that we've discussed.
I don't know, just keep going, keep building relationships, slowly chip at them. I'm finding it a little bit difficult out here because I can't do my chronic disease portfolio and continue chasing these younger adolescents with diabetes and that. Understaff is a big issue here now. So keep trying, I guess, when I do bump into them, just build that relationship and then sort of encourage them to come in. Maybe we can start again, start fresh and find something that suits them, their lifestyle, their family, and bring everything together and sort of work on the plan and slowly chip at it. Like you said before, I think it might have been Jenna, don't throw too much in, might cause them more problems. Just slowly, small changes so it helps them longer down the line and that. Yeah.
Thanks, Raymond. Yeah, it sounds like really challenging circumstances that you work into, you know, with resourcing and staffing and the job that you've got to do. So I really appreciate you coming on today.
No worries. Thank you all. I might have to take off. I've got the rental team out here.
Yeah, no problem. Thanks, Raymond. I'll finish off by thanking each person personally. So Michelle, Emily and Jenna, thank you so much for being involved in the panel discussion for the case study series. You know, these things wouldn't be what they are without, you know, clinicians as experienced as yourselves coming on to discuss these complex cases where there aren't easy answers, but it's really good to have some discussions about them and learn from each person's experience. So thank you so much for taking the time out from your busy days, from seeing patients, from all the other priorities that you have to be involved. I know I really appreciate it, and I'm sure all of our participants do as well.